Hi, everyone. Welcome to today's CME. I hope you're having a good day. We are going to give about 5 minutes to get a few more participants on, and then we'll start. Welcome, Dr. Mwanje, Dr. Bridget, Dr. Cornelius, Dr. Bua, Dr. Edwin, Melkia, Konge, Fatuma, Kawesi, Waswa, Immaculate, Agaba, Waswa, Fiona, Richard, Dr. Mwase, Ruth, and Semei. We'll be starting in a few minutes. So it's 36 past 5, and we're going to begin. Just a reminder to everyone, if you have a question, you can type it in the chat and we'll read your questions at the end of the presentation. You can also raise your hand. You'll be able to raise your hand if you want to ask a question to the presenter directly and or contribute and have us hear your voice. With this format of Zoom, you'll not be able to, you'll be muted already. So you'll just get to unmute yourself when we'll be able to enable, the unmute yourself function is disabled for now, but we'll be able to enable it later if you want to speak. Okay, so welcome to our first CME of the year. Our topic today is continuous spinal anesthesia for abdominal surgery, and our presenter is Dr. Andrew Emyedu. Dr. Emyedu is a young anesthesiologist. He's scrub say anesthesiologist, but his certificate is coming in soon. We're waiting for the graduation party. He has special interest in regional anesthesia, pain medicine, and acute chronic pain, all kinds of pain, and perioperative medicine. So he's also a recently published author of a case report, which he'll talk about in this presentation. And I hope you're all excited for this talk and prepare your questions. And we'll have Dr. Emyedu hopefully answer all those questions. Okay, Dr. Emyedu, welcome to the CME. Please feel free to start. Thank you all.
Hello, everyone. I am Dr. Andrew Emyedu, an associate member of the Association of Anesthesiologists of Uganda. I'm happy to be the presenter of our first CME this year. It's on continuous spinal anesthesia for abdominal surgeries. I hope you can all hear me.
We can hear you well.
I have no conflicts of interest. This talk wasn't sponsored by any drug companies or manufacturers of any of the gadgets we are going to talk about. We are going to talk about continuous spinal anesthesia, and under that we shall look at the history, the current practices, the currently available gadgets. We shall have a case discussion and a take-home message at the end. It should take about 45 minutes. So continuous spinal anesthesia is one of the oldest regional anesthesia techniques described. It's also the least utilized. It was first described by Henry Dean in 1906, a surgeon who described performing abdominal surgeries using single-shot spinal anesthesia. And he wrote about his cases, explaining his experience. Most of the complications he got were involving regression of the spinal anesthetic. Patients were uncomfortable midway during the surgery, and at the end of surgery, they would also have increased tension of the muscles. So closure of the skin was at times more difficult than performing the surgery itself. So he then suggested an idea where a spinal needle would be left in the back and intermittent boluses of the local anesthetic would be administered through that. That didn't catch on until 1940, when William T. Lemon described 200 cases in which he used continuous spinal anesthesia. At his hospital, he designed a special bed which had a special mattress, and that mattress had a hole through which the spinal needle would pass, and then it would be stuck into the patient's back. So this is how the procedure went. The patient would come in, of course, informed consent obtained. Then the patient would lie in the left lateral position, and then a spinal would be performed. So at the time, they didn't have the special needles, so they would cut somewhere on the back, so that then the needle would be passed through that. The care would be taken not to cut through the interspinous ligament, so that because that is what used to keep the needle in place. So the spinal would be performed. When it gets loss of resistance and CSF flow, it would then be connected to this tubing, which was connected to a syringe, which was rested on that bed. So then the patient would turned supine. So at the start of surgery, they would draw 10 mils of CSF, which was mixed with the local anesthetic, which was tetracaine at the time, and then it would be re-administered in boluses to achieve good surgical coverage and maintain that coverage throughout the procedure. That same technique was borrowed by some obstetrician in the same institution that used the same technique to perform labor analgesia for patients who are going through labor. So Lange and his colleagues described 50 cases in which they used the same technique to perform a continuous spinal analgesic, in this case, for 50 cases, 50 women that are going through labor. And in their report, they described how this would sort of hasten cervical dilatation, and the patients had non-eventful deliveries. The issues they complained about were lack of the proper delivery bed. So the patients would have these needles placed early in labor, and then when they are about to go through the second stage of delivery, where they would be moved to another bed, that particular delivery bed didn't have the hole through which the needle would stick. So that was one of the major issues they faced. Then they also reported that 46% of the patients had post-dural puncture headache, but at the time it wasn't considered a big deal because it was a small price to pay for pretty standard painless labor. Then the same gentleman who described this bed described another 2,000 cases where that technique was used to perform surgery for abdominal as well as obstetrics and gyne cases. He still, in his major difficulty, said that the issue was difficulty maintaining the catheter in place or the spinal needle in place. Then came this gentleman, Edward Toy, who is famously known for the toy needles. He described use of a 4 French urethral catheter, which would be advanced into the intrathecal space and left in place, and then medicine would be administered through that. As you can imagine, the levels of post-dural puncture headache then went up, and so at that point, that was what the anesthesia community was tackling, post-dural puncture headache. The idea was you have created a hole in that dura, so CSF keeps leaking. When you reduce the CSF volume, you have tagging on the meninges and a compensatory increase in cerebral blood flow, which would all lead to headache. So then they, of course, knew it was because of the catheters. The 4 French catheters were quite big. So they decided to come up with a solution, which was microcatheters. Several microcatheters were described in 1964, but one that stood out was by Kali et al. In 1990. That is quite recent. So this was the regional anesthesiologist who described using a 32 gauge catheter, which would be passed through a 26 gauge spinal needle, and this would help reduce the size of the hole created in the dura. And since it's very small, it will also prevent post-dural puncture headache. So then, of course, many studies came up describing use of these 32 gauge catheters for abdominal, lower limb, as well as labor analgesia. One of the major issues was difficult placement. You can imagine passing a 32 gauge through a small spinal catheter. The other one was about, but this didn't really stop use of this technique. So several studies came out until 1991, when Rigler and his colleagues had a case series of only 4 cases of patients who were initially very fine, went through various abdominal surgeries, and they developed Kyoheirwe syndrome. Kyoheirwe syndrome is a permanent neuropathy affecting the sacral and lower lumbar nerves. So these patients had difficulty voiding, so they required urinary catheterization. Some had fecal incontinence, loss of sensation in the perineal area, and sometimes the upper thigh. So these were 4 cases, and from that, several theories were then coined to sort of explain why these patients were developing this condition. The first culprit was microcatheters. So in their argument, since you have a very small catheter through which you're administering medicine, the spread of that medicine is not going to be well enough. Most of the medicine will stay in that one area due to the limited flow. And the nerves in that area, which was usually lumbar, because most of these continuous spinal anesthetics are being performed at lumbar level, you would then have exposure of those nerve roots to high concentrations of these drugs, which would lead to some damage. So microcatheters were then banned by the FDA, that was in the US. And then after that ban, several studies continued, and the next idea was about the lidocaine. Initially, they were using 5% lignocaine, which is a high concentration. So for this, this was done mostly in animals and in the lab. So they used nerve extracts which were exposed to this 5% lignocaine, and they then examined them for histology and found some demyelination and some changes on the nerves. So then they decided to, okay, the idea was then that the 5% lidocaine is the one that is causing the neurotoxicity. So it was until 2008 that Akosh and his friends decided to get the ban lifted so that they could test safety of the 28 gauge catheters on mothers. These are obstetric anesthesiologists, and in their study, none of the patients had Kyoheirwe syndrome. In 2012, another study by Lux and his colleagues found a retrospective study showed that in the 1,212 cases that had continuous spinal anesthesia, none of them had developed Kyoheirwe syndrome. So following that, they decided that the microcatheters were safe because in both studies, the similarity was none of them used 5% lignocaine. They each used bupivacaine and safentanil. So currently, as of today, continuous spinal anesthesia is safe, and these are the currently available sets. There is a catheter over needle set that is by B. Brown. It's called a spinal cath. It has that same appearance of a cannula. So there is a stylet and then a catheter over it. So you can advance it, perform a spinal the same way you would on any other day. And then you take out the stylet, you leave the catheter in. And since it's really small, the dura also collapses on that catheter. So that further reduces the incidence of post-dural puncture headache. The other one is called the ultra-long catheter by Payunk. It uses the Feldinger technique, and this is the set. It looks more like a central line set. It has a sprout needle, which is graduated, and then it comes with a connector, a filter, a syringe, and the catheter with a guide wire within it in that format. So when performing this technique, of course, where the patient comes in and you would do the same things, of course, consent, with the patient in a sitting position. You would have to get asepsis using maybe alcohol or iodine. Then you infiltrate with a local anesthetic. After identifying your point, it can be usually lumbar. Then you would perform a spinal using the sprout needle. So you advance the needle, checking for CSF, and then remember the needle is graduated, so you can, if you have an ultrasound, you can actually identify the trajectory of the needle as well as how deep the needle should go before you hit, you get CSF. Then occlude, when you get CSF, you have to occlude and organize. Usually you need an assistant for this, but you can then organize to do the next step, which is sliding in the catheter. So since it uses Feldinger technique, I think we are all covered that with the central line. You just advance it through the catheter. Usually that should prevent CSF flow. And then you can remove the sprout needle. The sprout needle has a small bump at the tip, which sort of directs the catheter cephalad. So then you will take out the guide wire. Then at that point, the guide wire as well as the sprout needle, and most of the studies I've seen, they leave in 3 centimeters beyond the tip. So if you got CSF at say 5 centimeters, you then pull the catheter out up to about 8 centimeters, leaving in 3 centimeters extra. That is to account for in case of any movements or displacements during the surgery. So you can as well check and see, you can sometimes see CSF flowing back. So then you connect your connector where you can administer your medicine and administer your medicine. Usually you can start with an opioid and then the rest is the same stuff that we know regarding epidural placement. You secure the catheter so that it stays in place. So why should we conduct continuous spinal anesthesia? I think we have so many anesthetic techniques as it is. So why would you think of a combined spinal anesthetic? One, I think it's easy to perform. I have never done one using that set. So I think if any of us is given these sets, we wouldn't have any difficulty performing this particular anesthetic. It's been used mostly for patients who have had previous back surgery. We are starting to get a number of spine surgeries ongoing in Uganda. So maybe in the near future, we shall have these patients coming back for maybe lower limb surgery and we know the anatomy has already changed, and due to the scarring, you don't have enough spread of the drug, so you need something more fine and where you can administer much lower drug volumes and doses. It's used also for long lower limb surgeries. Say you have a patient who has had polytrauma and needs some lower limb surgeries and maybe upper limb surgeries, but you don't want to do a general anesthetic. If you place an epidural, you're going to go towards the toxic range of most of the drugs. So if you administer using continuous spinal anesthetic, you're allowed to use much less medicine to achieve the same levels of anesthesia as you would for an epidural. It has been used also for patients with some deformities like scoliosis. And then the case reports that you will find are mostly regarding cardiac disease. It's said that, okay, when you use this technique, since you're administering little drugs at a time, you're able to control how high your spinal should take, so you can actually avoid any cardiac derangement. So it's one of the techniques that is advised for cases where you want to maintain cardiac stability. It has been described in cesarean section for patients with valvular heart disease, rheumatic heart disease, and the elderly patients that will not, who are frail, and you don't want to avoid any form of derangement, as well as pulmonary hypertension. So can it be used for abdominal surgeries? This is what we are talking about, continuous spinal anesthesia for abdominal surgeries. So when we are presented with a patient who is going to undergo an abdominal surgery, general anesthesia is usually our default technique. And the reasons are valid because, one, you have protected the airway. Two, you can maintain surgery for as long as you can. We have colleagues that are performing surgeries that take about 8 to 13 hours. So general anesthesia is good for such. Then if you add a muscle relaxant, you have good muscle relaxation and a good surgical condition for the abdominal surgery. So general anesthesia is the plan A. However, you may have patients that may not tolerate the general anesthetic. So what else can we use? A single shot spinal anesthetic is not ideal. It has been modified by various anesthesiologists to try and cover the abdominal wall, but the issues are still the same. It regresses quite fast, so the patients will have pain or discomfort midway during surgery, and then at the end of surgery, the muscles will get more tense. So closure of the abdomen will be more difficult. The other option you can do is epidural anesthesia. For this, you would have to use a higher concentration of the anesthetic, say 0.5 bupivacaine, so that to achieve good surgical conditions. But if you're to do this for surgery that is going to take about 3 to 4 hours, you're going to use most of the bupivacaine that has been supplied for that day on one patient, so it doesn't make financial sense. And regardless of whether your surgeons tell you they're going to take 45 minutes, sometimes it's 45 can turn to 3 hours. What else can you use? So continuous spinal anesthesia is another valid option. So continuous spinal anesthesia, you would perform a normal spinal, give you the usual drug you would use to activate your spinal, and then when it starts to regress, you can just keep administering more drugs. So what's the advantage of this? One, cardiac stability, we already talked about that. You can give little, small aliquots until you achieve the levels you want. Ideally, cardiac anesthesia should be asking for this. But since we work in regional and national referral hospitals, we see the sickest of the patients, so you never know when you will get one that needs it. You also give very low doses. The most studied additional doses are 2.5 milligrams, that is 0.5 of a meal, whenever to just maintain your surgical anesthesia. So you have lower chances of local anesthesia toxicity, regardless of how long the surgery takes. You can sustain the surgical anesthesia for a prolonged period since you have a catheter. So a patient may be uncomfortable, but since they are awake, lying on the same bed. So you may have to sedate them at some point, but as per the surgical anesthetic, you can actually maintain it for a prolonged period of time. And if you leave the catheter in place, you can actually provide a pretty standard analgesia postoperatively using either a local anesthetic or an opioid, and at much lower doses than that you would use for epidurals. So epidural analgesia is a gold standard, and continuous spinal anesthesia actually provides comparable levels of analgesia. So it's a valid option, and it's also more superior to compared to the abdominal wall and thoracic blocks. So that being said, we don't have these sets in East Africa, and we have looked. They are not there in Kenya. The suppliers don't have a reason to bring them because no one is asking for them, and it doesn't make business sense to provide things that people are not using. So I guess with this information, we are going to start asking for these sets, and then they will be made available. So did you just waste 45 minutes talking about something that we cannot apply? There is something else we can do. You can use this information in another way. So like we said, epidural analgesia is a standard analgesic technique for the perioperative period for thoracic, abdominal, and lower limb surgeries. So we do them a lot in our setting, but epidural placement is a skill that has a particular learning curve. So we are going to have various complications during epidural placement. We need about 60 epidurals to become proficient at epidural placement. So say if you are in year 1, you're not going to place an epidural. In year 2, you will start. Then in year 3, you'll be doing research. So you will not have enough time to actually achieve the 60 epidurals, and they shouldn't be so spaced apart. So how can we use this? There's a wise man that usually says, you chaps need to invest in your learning. This gentleman, he said this regarding epidural placement and TIVA, because most of us used to wait for sets that he had in his bag and some of the drugs that he had. So at one of the morning meetings, he said, you can't wait for me to bring my sets, my perfuser lines, my 3-way stop cough, my remifentanil, for you to go and try out these things, skills that will help you. You need to invest in your learning. So following that, a bunch of us in 2017-2018 cohort decided to go out and procure epidurals in bulk. What followed, of course, this wise man didn't like, because every patient got an epidural from POs to Whipples and stoma reversals. If he let us, some people for hemorrhagectomy would have had epidurals as well. So we then, of course, got to see a bunch of complications regarding epidural placement in our small main theater. The most distressing was accidental dural puncture. So we've all been there. You have told your patient, you have consented you're going to perform a procedure with maybe 1 or 2 attempts, and then you're advancing the needle, you get loss of resistance, and then CSF flows. Usually it looks like that. It's usually much less, but when it happens to you for the first time, it looks like that. So the natural instinct is to pull out the needle and maybe have another attempt at another point, which is usually by a more senior resident, or usually by a more senior resident, or by a senior. Or the other one is to convert to a spinal anesthesia. So what I've seen being done is, for say lower limb surgery, if you puncture dura, you get your spinal anesthetic and administer it through that same dural puncture. That same dural puncture, so that you can perform convert it to a spinal anesthetic, basically. The other people, eventually, you can abandon the procedure. You put away whatever gadgets you have collected and put them away, because at that point, everyone is not happy with you because they've taken up all their time. And then you do a standard general anesthetic with multimodal analgesia, so that, which is also quite okay. So what's the problem with accidental dural puncture? It happens to everyone. The incidence is 1.8 to 3.6%. That is a very low number, and that's because that meta-analysis was conducted among obstetric anesthesiologists. So it happens to them too. However, the incidence is much higher in our small main theater where we have the people under training. What's the biggest problem with accidental dural puncture anyway? So 6 to 8 out of 10 of the patients will get post-dural puncture headache. Post-dural puncture headache can be a headache to the patient and to the anesthesia person. So this has, and the incidence is quite high. So this is almost 9 out of 10 patients will have post-dural puncture headache. So this has led to, of course, various studies to warrant how to prevent this from occurring. So that is sort of beyond the scope of this talk, but briefly, one of the most spoken about is administering intrathecal morphine. Intrathecal morphine, using its analgesic properties, will prevent this headache from occurring. Or epidural blood patch, which is the most invasive of them all. It involves asking the same patient to come back and have an epidural placed at usually a proximal site, and then autologous blood would be administered through that epidural. The idea is that blood will then clot at that point where the puncture has been made and prevent CSF leakage. But it's quite invasive. The other technique that seems to be gaining public interest is intrathecal catheter placement. So if you have punctured dura, you can advance the catheter through that the epidural needle into the intrathecal space. And how this works is, one, it can act as a mechanical block to the CSF flow, preventing CSF flow. You can leave it in place and keep administering intrathecal morphine. And if it is left for 24 hours, the incidence of PDPH is dropped even much further. Sabri and colleagues, obstetric anesthesiologists, conducted this study where they had, over a 5-year period, they had 115 accidental dural punctures. And these patients were randomized into 3 arms. In one arm, the epidural would be performed at another point. In the second arm, a catheter would be advanced into the intrathecal space, and then continuous spinal analgesia would be performed. Then the catheter would be taken out immediately after the lady has delivered. In the third group, the catheter would be advanced through that hole, and then continuous spinal analgesia performed still, and then it would be left in for 24 hours, then taken out. So the patients that had the epidural catheter left in place for 24 hours had much less levels of PDPH, and of course more satisfaction. Which brings me to our talk today. We have a case on continuous spinal anesthesia following inadvertent dural puncture. This was published 3 weeks ago in Hindawi. You can look it up. I'll leave it there for people to see. But basically, in brief, we had a patient, a 38-year-old patient with no comorbidities, who presented with a 1-day history of abdominal pain, colic in nature, abdominal distension associated with bilious vomiting, and bilious vomiting. And he had history of surgery in the past 13 years prior to that presentation, which was uneventful. And at this point, he had an ultrasound that showed features of intestinal obstruction. So he was diagnosed with that, and he was going to undergo emergency expiratory laparotomy at our A&E under general anesthesia and epidural as the analgesic of choice for intra and postoperative pain. So of course we consented him. His labs were good. The HP was 11.9. White cells were normal. So we then consented him for an epidural and transferred him to the operating room. And in sitting position, we cleaned the site, located our area. We chose between T10, T11 interspace, which we then infiltrated with local anesthetic, and then the epidural process started. We advanced the toy needle and got loss of resistance at 5 centimeters. However, when we took off the needle, the loss of resistance range, we had also CSF flowing. We knew we had a wet tap, but since we knew some of this theory, we then got verbal consent from the patient to advance the catheter and perform a continuous spinal anesthetic. So the catheter was advanced 3 centimeters beyond the tip of the toy needle, and then taken off and secured in place. We activated the continuous spinal anesthetic with 10 milligrams of isobaric bupivacaine, which was administered in 5 ml aliquots to achieve good surgical blockade from T4 to L2. He had a Bromage score of 1. He could move his arms and limbs. And at midway during surgery, we had to top up. We topped up with 5 milligrams of bupivacaine, at which point we had an episode of hypotension, which was controlled using an infusion of adrenaline. This was 300 micrograms of adrenaline put in a 500 mils of bringers lactate. Of course, we didn't have a pump, so that is what we used in this case. We maintained maps above 65, and then the patient intraoperatively received an additional 100 micrograms of intrathecal morphine. And during surgery, they found gangrenous gut, and the catheter and 35 centimeters was resected. So we transferred him to the surgery. Went on well. He received 1.5 liters of fluid, as well as blood, 180 mils of O negative blood. And at the end of surgery, he was transferred to the recovery area. He was hemodynamically stable at this point. And then from there, he was transferred to the parent ward, where he stayed for 1 day and then transferred to another ward. So the next day, he was assessed for post-dural puncture headache, which he didn't have. He didn't have any pruritus. He didn't have any of the neurologic complications, no paraplegia. He didn't have any paresthesias anyway when we were placing the epidural or advancing the catheter. So postoperatively, he was given 100 micrograms of intrathecal morphine, which and then the catheter was taken out. The catheter tip was checked, it was complete, and he didn't have any complications. He was then followed up by the surgery team for 3 weeks using weekly phone calls, and he didn't have any neurologic complications following that surgery. So this is the first case report from our system where this technique has been used. So in our opinion, it's a safe technique, it's valid. So the next time you have an epidural, an accidental dural puncture, you can actually advance the catheter and give the patient a pretty standard anesthetic technique that is safe. However, we need more studies to generate a pool of literature where we can actually, which we can base on to say this procedure is safe. So we may need maybe an RCT in the near future. So from I was asked to say something about continuous spinal analgesia for labor. I haven't had an accidental dural puncture during labor, but if it happens, you can also advance the catheter into the intrathecal space. This is literature. This is from a study by those of Akosh, an obstetric anesthesiologist. So they used sufentanil and bupivacaine in 400 patients who were randomized to either receive continuous spinal analgesia or epidural. And it was a randomization of 3-to-1 since they were testing continuous spinal anesthesia versus a gold standard, which is epidural analgesia. So they had, they gave the patients sufentanil and bupivacaine, and the patients who had continuous spinal anesthesia had lower pain levels, which lasted a longer period compared to the patients who were in the epidural arm. There was a faster onset of the block. That means you have faster confirmation of proper placement of the catheter, as opposed to epidural placement, where sometimes you may need about 15 minutes to actually confirm. And if the patient is uncooperative, it may make it even worse. There was less motor blockade on the continuous spinal anesthesia arm. That's because they gave them opioids, which apparently which reduce the need for bupivacaine. There was no difference in neonatal and maternal outcomes. There was no difference in cesarean section rates. There were, of course, higher levels of pruritus in patients who had continuous spinal analgesia, and there was twice as much incidence of posterior puncture headache in patients who had continuous spinal analgesia. 9 versus 4, that is quite low, but significantly high. There was no neurological damage in the continuous spinal anesthesia arm. So remember this slide. In case you have an accidental dural puncture, you can advance the catheter in and give the patient very low doses of 1.5 of bupivacaine. If you're giving intermittent pulses, you may need maybe 1.75 to 2.5 milligrams, which is given 1 to 2 hourly, as opposed to those who have done intermittent pulses with epidurals, you have to dose every 30 minutes almost. And then for a continuous infusion, you can also use 0.05 to 0.125, set at a rate of 0.5 to 3 mils per hour. That is quite low. And then you would have still the same labor analgesia for this patient. With that, our take-home message is continuous spinal anesthesia is safe. It's out there, it's being done. The sets are available. You do not have to wait for accidental dural puncture in order to perform continuous spinal anesthesia. You can actually look for these sets and perform a continuous spinal anesthetic using the proper sets. If enough of us ask for them, they will be made available. Accidental dural puncture happens to all of us. If it happens to you, you have options. Take a deep breath. Ask the surgeon to record a video as you perform a continuous spinal anesthetic. Thank you very much. Bernadette.
Thank you, Andrew, for that interesting, informative talk. Do we have any questions at this point? So Dr. Andrew, there's a question for you. How much would a continuous spinal anesthesia set go for the open market? Do you have any idea? When you found out that there are no sets in East Africa, how much did they say the sets would cost if you found out?
Okay, so for most of the sets, they want the intralong is $100, but that's because you're buying few. But if they are bought in bulk, there is a contact, the gentleman that supplies B Brown products says the price can go lower if the things are if a number of us ask for them, so we can get them at maybe 150,000 Uganda shillings.
Okay. So fortunately, B Brown is one of our sponsors for conferences and other talks. So we'll hopefully be able to get more information and share with the whole group if those sets are available and how much it will cost. So another question, is there an increased risk of total or high spinal with continuous spinal anesthesia?
Thank you. So with continuous spinal anesthesia, from what we've just discussed, you're using much lower doses to actually achieve the appropriate anesthetic level that you want. So say for our case, we used 10 milligrams, that is 2 mils of the local anesthetic to achieve good surgical blockade. And then if it regresses, you administer as little as 0.5 mils, that is 2.5 milligrams to maintain the block. So the chances of getting a high autospinal are much lower because you start with much lower doses. Actually, in most of the case reports I've seen, for lower limb surgeries, you can use 7.5 milligrams of whatever drug you're using, and that's because you know you can actually add any medicine in case you give less, as opposed to the single shot spinal anesthetic, which people have modified. If you want to do maybe abdominal surgeries, you may have to give a larger dose of 15 to 20 milligrams maybe in order to achieve good blockade. So you don't know where the drug is going to end up. Also with epidurals, you have to give a much larger dose, and you don't know where it's going to end up. But if you have a continuous spinal anesthetic, you can start as low as 5 milligrams and then keep adding 0.5, 0.5. So you can control how high the spinal goes. So I think you would have a much lower chance of getting a high or a total spinal. Thank you.
Thanks, Andrew. Dr. Cornelius, your hand was up. You should be able to unmute yourself and speak now.
Hello, Andrew. How are you?
Yes, Cornel, I'm okay.
Yeah, thank you so much for the presentation. It was very succinct and I think quite informative. I enjoyed it. Thank you so much. And congratulations on the paper, your first publication. I'm sure it was an ecstatic feeling. So my question to you are going to be, I don't know if they will be difficult to answer, but the first one is, considering the setting that we are in at the moment, and I know you did this particular case in casualty, where I think it may sometimes be dangerous to even give a DA. So considering the setting we are in and probably other settings that are similar to ours, would you then, based on what you did and the feasibility of it, would you then potentially advocate that we do more continuous spinal anesthesia for emergency laparotomies as compared to DA based on the setting? And then the second thing is, by your opinion, do you think this would offer us a better chance of providing, say, because the paper you presented, say, on labor analgesia in women, should we then move on to providing continuous spinal instead of epidural for labor analgesia? Because we know, yes, there may be an increased risk for posterior puncture headaches, I do not know if that paper demonstrated whether that was a significant difference between the two. But do you think that there will be a time that would be the appropriate move to make for women in terms of anesthesia? Because if I have to, for example, go for emergency cesarean section and I have a continuous spinal, I think it will have a much better blockade. Also, the other advantage maybe it would provide is that it's less likely to have a patchy block compared to an epidural. So based on that paper and what is being maybe envisioned for the future, do you think we shall reach that point, or would you, in your opinion, advocate that we go ahead and puncture these durals of these women and just thread in the catheter? Yeah, so I think those are my questions for now. Thank you.
Okay, thank you. So the first question was whether we should move on to continuous spinal anesthesia as opposed to general anesthesia in our setting. So in order to do continuous spinal anesthetic, first of all, intraoperatively, it's going to help you achieve the proper blockade. The main issue that's usually feared is, which if people have done emergency laparotomies using epidural anesthesia, is when the surgeons are tagging on as the block regresses, when they start tagging on the momentum or peritoneum, the patient can sometimes get uncomfortable. So you have to top up to maintain that level of blockade. So if you don't do it so well, the patient can actually can vomit. But with the continuous spinal anesthetic, it's one case, so we can't really draw much from it. But it's easier to the block sets in much faster, as opposed to epidural where you top up your epidural and then the block will still take some time, so it may not be the best. So with continuous spinal anesthesia, I think if you can actually control the level of blockade that fast, then I think it would be more ideal in that setup of emergency surgeries. More so now that we don't have, the monitors in some of the places, and maybe suction is hard to come by. If you can use a less, maybe an anesthetic that doesn't take over, that doesn't let you control much of the patient's maybe breathing and cardiovascular system, then you can go for that. You can do it with much less monitoring than GA. So in my opinion, yes, it should be done for emergency anesthesia, emergency surgeries. However, for you to do continuous spinal anesthesia, it needs to be also the postoperative area needs to be organized and ready to receive such patients, because you have a catheter that is coming all the way from the outside and going into the patient's intrathecal space. So if you're not comfortable with the hygiene of the area and how the catheter is going to be handled by the nurses are already struggling with epidural and analgesia postoperatively. So then you introduce continuous spinal anesthesia, which they may not understand. You may actually get higher chances of drug errors. So maybe the system is not so ready. In one of the papers I read, it was advocated that these continuous spinal anesthetics need to be done when the patient is going to be sent to an HDU, where you can then assign one nurse to that patient, and also with the exact drug doses and regimens to give. It's a good an alternative anesthetic technique for emergency surgeries, especially in our setting. However, I don't think the system is ready for that in the postoperative period. So I don't think we should do it now. Maybe in the near future, yes, it can be done. Then the second question was about continuous spinal analgesia for labor. So from what I've read, I think the continuous spinal anesthetic provides much better labor control if you administer, if you place an epidural, you need some time to confirm. More so if you find a patient who is already midway labor, maybe 6 centimeters, they're already having contractions that are quite frequent. And when they see you enter the room, they think their pain is going to go after that injection that you have just placed. However, when you place an epidural, you still need time, about 15 minutes. And in those 15 minutes, they may have about 5 to 7 contractions, which are going to be strong. So they will not be as happy with you. If you place a continuous spinal anesthetic, on the other hand, you can achieve motor blockade maybe in less than 5 minutes. You achieve the pain reduction in less than 5 minutes. So that way you can actually confirm that the catheter is in place, as opposed to an epidural where you have to wait. In some of the cases, there's a small group of us that uses lignocaine combined with sodium bicarbonate just to hasten the onset of the epidural, more so for patients that are already midway the labor process. Then you maintain with bupivacaine. So with a continuous spinal anesthetic, you do not need that. Then the cost of the set may be higher than the epidural set, but I think in the long run, if you look at the drugs that you use in terms of volume and concentration for epidural versus continuous spinal anesthetic, the drugs are going to be significantly less in your continuous spinal anesthetic. So you never know with time that the price may drop. Then if you leave it in and still in the postoperative period you use that, the drug will drop even further. So the price may not be a main issue, because the drugs that you use in an epidural are going to be way more than what you would use in a continuous spinal anesthetic. I do not think we should go and puncture dura with epidural sets, since it's a good technique. No, this we can wait for the proper continuous spinal anesthetic sets to be brought. They are out there. We just have to ask for them. But in the event that you get an accidental dural puncture when you're placing an epidural for labor, which is actually more likely to happen because the woman is already contracting and they're not sitting still, you may actually puncture dura. If it happens, you might as well put the catheter in and perform a continuous spinal anesthetic while preventing post-dural puncture headache and also maintaining good post-delivery, pain levels with that same technique. But we should not puncture dura. The 9 versus 4% that had PDPH in the continuous spinal anesthetic versus in the continuous spinal anesthetic arm versus epidural, it was significant because it was actually twice as much. It was significant, but it was also well controlled. The catheters were also left in for a short period of time. Maybe if you modify that, you could have a good anesthetic. But no, you shouldn't puncture dura intentionally. You can ask for the set. Thank you.
Thank you, Andrew. I hope Cornell is satisfied with your response. So following up on continuous spinal anesthesia for labor, does the volume of the anesthetic that you've used or the drug you've used matter?
Is that for anesthesia?
No, that's for analgesia for labor.
Oh no, for analgesia, it's a small concentration. From the slides I shared, the concentration you're going to use is say 0. Yes, you make a small concentration of 0.05 to 0.125, and you can administer a small volume of say 5 mils. But of course, you have a spinal and a catheter into the there is no for what I've learned, at least as up to now, there is no standard volume that you're going to give to achieve a particular level of blockade of analgesia for someone undergoing labor. And this is a new technique, so I think you would start with a low volume that you're comfortable with, and then if it's not sufficient, you have a catheter in, you can actually add, as opposed to starting with a large dose, which you can't take out anyway. So start with a small dose and then keep adding. I don't know if there's a fixed volume. I don't think there is, but you can just keep administering a small volume, and if it's not enough, you add another volume of a low concentration, because you want to only cover, you don't want motor blockade. So you use a very low concentration of 0.05 to 0.125 to achieve good analgesia and no motor blockade. Then add more opioids in there as well.
Sorry, could you just say how many mils of that you said you would advise to give?
So let me put this slide back. So this is from a study that was already conducted, and these are the volumes that have been accepted by the people out there. So if you're using intermittent boluses, you have 1.5 to 2.5 milligrams. That is 0.5 of a mil with fentanyl administered every hour or two, yeah, to achieve good labor analgesia. Then if you're using a continuous infusion, you set a very low rate of 0.5 to 3 mils per hour over 0.05 to 0.125. So these are very, very low volumes because you're already in the intrathecal space, as opposed to epidurals where you have to place larger volumes, activate with maybe 10 mils or 15 mils of whatever concentration you're using. So yes, the volume is much lower because you're already in the intrathecal space and you're adding opioids to it so that you can use less of the local anesthetics anyway.
Okay, thank you, Andrew. We have a question here. So considering the fact that in Uganda, most of the anesthetics are given by anesthetic officers, do you think this is a technique that needs to be taught to them?
I don't know. Okay, I don't know what their curriculum has. I don't think they do epidurals as well. So in my opinion, a continuous spinal anesthetic is technically more tricky than an epidural. So I think if we are to, I don't know what the scope of practice is and whether they're allowed to try to experiment with these things. I don't know, maybe Fred will help us with that. But in my opinion, maybe it should be the anesthesiologist doing this. And seeing as performing this technique also requires you reading up and developing your own way. There is nothing set in stone. I think everyone will have to read. So the anesthetic officers will also have to sit down and probably read and then experiment and see what works for them. So it's usually easier if you have something that you can standardize and then you can teach everyone, as opposed to continuous spinal anesthesia where it's variable. For every patient, you may have to do something different. So I don't know. I don't think they are ready to be taught. Let's first learn it, because we also don't know it anyway. Then we shall see how it's taken up.
Okay, thanks, Andrew. And thanks for that question, Seme. That's something that we can forward to the AAU, since there's a team that's developing practice guidelines, which will be shared in the near future, hopefully. Okay, so we don't seem to have any more questions in the Q&A. So there's a question from Dr. Kyoheirwe, which was beyond the scope of this topic, but we can answer it now since we don't have any other questions. He was wondering if you could explain the stellate ganglion block. Do you have anything to say about that, Andrew? Do you want to present on the stellate ganglion block in another setting?
I don't know in what perspective has the question been asked. to just talk about the stellate ganglion block?
There was no context suggested. So, Dr. Kyoheirwe, if you're still on, could you please, I want to let you be able to unmute yourself so you can provide context for that question.
So for the stellate ganglion block, it's a block of the sympathetic nerve. It's used mostly for pain, which is sympathetically mediated. I don't know, it's really not in this scope, but if you have patients with, I don't know, any other condition with sympathetically mediated pain, CRPS, for instance, you can perform a stellate ganglion block. It can be done with ultrasound, with landmark. Landmark has been phased out because of the complications that can arise following that, but you can do it with ultrasound. The videos are quite many, and it's easy to perform. If you are comfortable doing peripheral nerve blocks, you can easily perform a stellate ganglion block. That can probably be talked about on another day. But we have a co-author, Patience Atumanya, who hasn't said anything. I don't know if she has anything to say on the side.
Dr. Atumanya, do you have anything
to say? You can unmute yourself.
I don't know what else you want me to say. I think
you can say hello.
Okay, hello. I think regarding that's a conversation that later it will be beyond the scope of what we're looking at. Now, regarding the combined, the combined continuous spinal anesthetic, I think in the right hands, it could be something that gives you a bit of more advantages compared to the other techniques. But in the wrong hands, it can also be a bit detrimental, and it needs to be utilized in a manner that is pretty safe for the patients, and also putting into account the side effects that might be not very fun for the patient, especially if, say, you notice most of when you leave a catheter, you're not quite certain if someone will end up opening it. And in the event that it ends up being opened accidentally and left open, the patient might have their entire CSF drained out in the middle of the night or something like that. So it's something that shouldn't be put in and left in a reckless area that might not be paying attention closely. Yeah, that's all I can say.
Thank you, Dr. Atumanya. We don't have any more questions for now. I'll just have Dr. Andrew give his final few words and reiterate his take-home message.
Okay, thank you. My take-home message is there are many techniques out there. Some are unsafe, some are safe. Continuous spinal anesthesia is one of the safe anesthetic techniques. It provides you with advantages of epidural analgesia and single shot spinal anesthesia while avoiding complications from general anesthesia for patients that will not benefit from the general anesthetic. So the sets do exist. We can ask for them and they will be made available. If you meet a big brown guy, ask for them, they will bring them. If enough of us ask per week, they will be brought at a much lower price. Then you can actually do the continuous spinal anesthetic intentionally. However, if you puncture dura, you can also provide continuous spinal anesthetic using that same 20 gauge catheter. you may need to ask a senior who I'm sure will always be available to guide you through the procedure. Thank you very much.
Thank you, Andrew. This was a lovely talk. Dr. Gaba asked for a closing prayer from me. Thank you. Thank you, Dr. Gaba, for that great contribution.
You should invest in your learning.
I will just remind everyone that your AAU subscription is due this month. Remember, for residents, you can be associate members. For people like Emyedu, please pay up full membership. And remember, it comes with lots of opportunities, health insurance, most importantly. And if you don't renew your subscription, you'll be scrapped from the insurance list. I also like to encourage you all to be willing to participate in AAU activities when called upon, moderate talks such as this, and also present. You could be the next presenter of your case done in women's or Kawempe or wherever. So everyone remember to stay safe. We still have COVID-19, possibly a new wave coming up. So stay safe, wear your masks and sanitize and all that. Have a good evening.
Is it done? Yeah, I want to talk now.